Good morning. My name is Katan Fada. I'm a second year resident from Texas Tech El Paso. We're very honored today to have Dr. Christian Jons with us.
My name is Christian Jons. I'm a consultant electrophysiologist at Rigshospitalet in Copenhagen, Denmark.
Can you tell us some of the background of the BIOGUARD-MI trial?
Sure. We previously did a trial enrolling patients from 2000 to 2005, which was one of the first trials to use loop recorders in post-infarction patients. Of course, it was different patients back then. It was also pre-primary ICD, and it was published in 2010. And it used one of the first generation loop recorders. But what we saw was that short-lasting arrhythmias, most of them nightly, most of them asymptomatic, were highly associated with future major events. So that's why we thought, when we see all this trial, actually half of the patients that died had AV blocks, and half of the patients that had AV blocks died. So we thought, what if we, and it was only short lasting. So we thought there's been now a number of trials showing that these post-infarction short-lasting arrhythmias are associated with higher risk. So, but can we do anything to change the risk to improve outcome? And that was the background for the design of the trial.
One of the things that I found really interesting was the risk parameters that you looked at, and CHA2DS2-VASc score. How was it utilized in the study?
Yeah, well, the patients, post-infarction patients nowadays are actually relatively low risk for a number of years to come. So if you want to change risk, decrease risk, you need patients who has a risk. And we were looking into an easily implementable and usable risk stratification tool that we could use. And the CHA2DS2-VASc risk score, we tested that in other populations, and we found it highly associated to future arrhythmias and to future cardiac events. And it's easy to use, and everyone knows it, so that's why we chose that one. Yeah. And
No, that's very impressive, and it's a good teaching point to all of us resident medical students and fellow in trainings how important this CHA2DS2-VASc score in arrhythmia in a population. What was the goals of the study, and were we able to achieve them during the trial?
Sure. So what we saw in our previous trial was that all sorts of arrhythmias, short-lasting AV blocks, short-lasting bradycardias, atrial fibrillation, and non-sustained VT, were all associated with the future cardiac events, new infarctions, heart failure, hospitalizations. So we made an algorithm where we defined how long the AV block should be and how short, and AFib episodes, we defined how long they should be. We had a monitoring board that would adjudicate these, from the ICM, the biomonitor. So when the biomonitor documented an arrhythmia, it was sent to a central monitoring board who would look at the ECG, and if it fulfilled the criteria, they would notify the primary investigator, and we would document the response time and the type of treatment they did. And that's the design of the trial. And then we documented the outcome of the patient afterwards. So once we randomized the patients and put in the loop recorders, we really tried to isolate the loop recorder effect or the biomonitor effects. So that's why we didn't call the patients. We had an external board call the patients, both the control group and the monitor group, every 6 months to gather cardiac events. We didn't want the sites to call the patients, just to isolate the ICM effects.
And was the goal and one of the aims of the trial to have a reduction of 25% of these events? Was that met during the trial?
It's a good question, and it's also a little bit a painful one, and I think it's also a good teaching point. The trial was planned to 372 events. There were planned 2 interim analyses, and we did have a data safety monitoring board of very skilled trialists. At the first interim analysis, they warned the sponsor that there were inconsistencies in the endpoint reporting in the control group. And an unblinded analysis, we saw that there were endpoints missing in the control groups. So there were non-cardiovascular endpoints missing. These patients had 40% less colon cancer and broken hips and so on. So we were missing things that were unrelated to the... And so we started looking for them for 6 months, stopped enrollment because it didn't resolve, and eventually they terminated the trial early. And we did plan, we made an amendment, called in patients to get these extra events, and when the trial was terminated in 2021, we had gathered, so the bias had resolved. There was no difference anymore, but we only had 218 events out of the planned 372. But eventually the primary outcome was not positive, so there was no difference in major cardiac events between the 2 groups. We did stratify patients according to the type of infarction, because non-STEMI and STEMI patients are very different. So they were randomized equally in both groups, and approximately 50% of the patients had non-STEMI and 50% had STEMI. And in the non-STEMI group, there was a 30% reduction in the major cardiac events, whereas in the STEMI group there was no effect. We went looking for why is there this difference. There's actually not major differences in the baseline characteristics, but the risk in the non-STEMI patients were just twice as high as the STEMI patients. So we had a lot more risk to change and reduce. And that's why we think it worked in these patients. The STEMI patients had a lot lower risk, so we didn't really change anything when we treated them.
Moving forward, is there like any future for a different trial or a different analysis that you would be hoping to achieve, given all these obstacles that have met in the field?
Well, I think it's 800 patients randomized with a loop recorder for over 7 years. It takes a long time to run a trial like this, so I think we won't see any trials in the next couple of years like this one. I think we show that you can change outcome by responding to asymptomatic short-lasting arrhythmias. And there's a future coming up with all sorts of devices that can measure body functions. And I think we show in this trial that heart arrhythmias is a good body function to measure, because you can change the outcome. Unfortunately, because the primary endpoint is not negative, we can't really recommend that you do it. But in high-risk patients, I think that this method has a way. Have we found the optimal high-risk population? I'm not sure. Right now, non-STEMI group is the best bit, but I think we will do a lot further analysis. It's a very large database in order to identify the true high-risk groups which we could recommend this treatment for.
Thank you so much, Dr. Jons.